Greetings. Today's PBH 275 lecture is going to cover two different injury topics which do have some similarities. We're going to talk about unintentional injury deaths in infants, and we're going to talk about intentional injuries, specifically the topics of child and elder abuse. To start, we need to acknowledge some of the reasons why infants, children, and the elderly have unique vulnerabilities that make them more susceptible to injuries when compared to the non-elderly adult population. First of all, and this is certainly the case with infants and very young children, but also the case in elderly people that have maybe had a debilitating stroke or who have dementia, is that sometimes these populations are nonverbal. They don't have the ability to express when something distressing is happening to them. These are populations that are often highly dependent upon caregivers. And sometimes, therefore, some of the emotions that the caregivers are going through will often result in injuries and abuse being given to these vulnerable populations. There's certainly cases of limited autonomy and being vulnerable to circumstances. Kind of covered that in the previous point. Finally, there's some physiological reasons for the increased injury risk in these populations. When we talk about infants, for example, they've got these things called fontanelles. They're soft spots on the skull that allow the skull to compress during birth, and they eventually harden up over time as the infant grows into toddlerhood and then to young childhood. But for the first several months, there's some soft spots in both the skull and other bones that make infants more susceptible to injury, particularly from things like accidental falls compared to older children. And of course, elderly populations, due to osteoporosis and other brittling conditions, will tend to have brittler bones, brittler or absent cartilage, tendons more susceptible to injury as well. And of course, there could be vestibular or balance issues that happen as we get older that make us more likely to fall. So, we will start with some data on infants. When I refer to infants in this lecture, we're talking about children under 12 months of age. In the United States, every year, approximately 3,400 cases of sudden and unexpected infant death occur. This is known as SUID. The most common forms of SUID injury are suffocation, entrapment, ingestion, and trauma. The word unexpected is important here when we talk about this number, about 3,400 a year. There are a lot of infants that don't make it to their first birthday because of congenital abnormalities. They were born premature. They just weren't ready to thrive and survive outside the womb. In this case, we're talking about infants who were born seemingly healthy, no underlying health conditions that were known, but then experienced sudden, unexpected death. You are probably familiar with the term SIDS, or Sudden Infant Death Syndrome. This is a term that's been used in our culture a lot, and SIDS is a form of SUID where the death of the infant cannot be fully explained even after a thorough investigation, including autopsy. SIDS will sometimes be due to bradycardia or very quick suffocation as a result of flipping over on the stomach and being engulfed in bedding, but it's not quite known exactly what was the final causative agent of death. So we're mostly going to talk about SUID, but if you hear SIDS, that term is still used, but it mostly means the SUIDs that were not able to be fully explained. Like many other forms of injury death that occur in the United States, sudden unexpected infant death is not seen uniformly across different race and ethnicity categories. These are numbers per 100,000 live births, so these are rates, not total numbers. Try to ignore the colors of the bars because Sudden infant death syndrome, there's still a little bit of controversy as to whether it's actually a separate thing from SUIDs. I mean, basically they're SUIDs where we don't know the cause, so really the orange and blue segments of the bars should be the same color. And then the green bar represents accidental suffocation strangulation where it was known and very well documented that was the cause of death. But these are all SUIDs, and you can see that American Indian and Alaska Natives had the highest rates of SUID, followed by non-Hispanic blacks, non-Hispanic whites, within Hispanics and Asian and Pacific Islanders having the lowest rates of SUID per 100,000 live births. So now let's turn our attention to the THAC article that you were assigned to read, the one on baby-friendly initiatives and the risk of SUID. Now, the baby-friendly initiative is something that has been endorsed by the World Health Organization and also the United Nations Children's Fund, or also known as UNICEF. It's an initiative that promotes, among other things, skin-to-skin contact between mother and baby. It also strongly promotes breastfeeding. Both of these are seen as very important for infant health because, first of all, skin-to-skin contact, particularly in the very early ages after a baby is out of the womb, is believed to lead to secure attachment to the caregiver. It helps babies feel more secure. It helps boost immunity. There's a lot of known health benefits for this. There's also possible lifelong nutritional and health benefits from breastfeeding. These are well established in literature. However, if you're going to do these sort of initiatives in hospitals, where you're going to encourage right after birth for the child to be held against the mother, skin to skin, both for breastfeeding and just for general cuddling in order to get that benefit, that careful monitoring might be needed, particularly in the first 24 hours after birth. The mother who's just given birth is often exhausted and in a great deal of pain. They might be on painkillers. They might fall asleep readily. And one of the risks for SUID is for when the caregiver is asleep and inadvertently rolls against the baby or can't respond to the baby when the baby's been held too close and is not breathing well, or that the baby is latched on for feeding for too long and needs to unlatch. So there's a little bit of a risk in doing this sort of intimate skin-to-skin contact between mother and baby, particularly right after birth. So this is an example in public health of how we can do things that we think are going to have a population-wide benefit, but we always have to be aware of possible unintended consequences of our interventions. One thing that's very interesting to me is that the baby-friendly initiative is still practiced here in the United States, but if you look at the baby-friendly initiative U.S. literature and information, it's almost exclusively talking about breastfeeding. There's very little mention about skin-to-skin contact. I guess part of this is in recognition of the fact that this can become a risk factor for SUID. You also were assigned the article from the American Academy of Pediatrics that listed out several recommendations for a safe sleeping environment for infants. I'm not going to summarize every single one of the recommendations. I will talk about a few of the key ones. Probably the most important key recommendation to avoid SUID or SIDS is that infants should sleep on their back until they're at least 1 year old. For many years, it was believed that you shouldn't have children sleep on their back because it might increase their risk of choking or of aspiration. We've since accumulated enough medical evidence to see that no, sleeping on your back as an infant does not really increase your risk of choking or aspiration, unless you're talking about a baby that's got a known upper airway disorder or a known gastroesophageal reflux disease. Sleeping on your back, even shortly after birth, when you might still have amniotic fluid that needs to come out, is still the recommendation, and it's a very strong recommendation, up until about 1 year. Another incredibly important recommendation for a safe sleeping environment is to use a firm sleep surface with fitted sheets. Infants should not be laid down on memory foam mattresses or really soft mattresses that tend to indent and kind of encircle them. There should be no other bedding or soft objects on the mattress surface with the infant that they can accidentally suffocate themselves against. This is something that, again, there's a lot of people that have believed over the years that it's good to have a lot of enrichment objects inside a crib or a lot of soft bedding that infants can kind of feel warm and secure, cuddled up in. But this does greatly increase the risk of inadvertent asphyxiation. So now most pediatricians agree that you should use a firm sleep surface with tightly fitted sheets. You should also assure that any crib or bassinet that an infant is laid down in does not have entrapment areas or design defects. The picture down here at the bottom of this slide, that's just a doll. They were using this to illustrate the fact that if you have a crib with a design defect, like in this case, the gate swings out and is not fully latched on the side, that creates an area where a small child or an infant can inadvertently slide down and become entrapped. Newer, modern, certified cribs also have slats that are very close together so that even the smallest of infants cannot wedge their head in between the slats of the crib. This is one of the cases where it's probably important to get a modern, certified crib and not use hand-me-downs or things like that. While the mechanism is still not fully known, there is quite strong epidemiologic evidence that breastfeeding significantly reduces the risk of sudden infant death. Another thing to do to avoid the risk of sudden infant death is to avoid co-sleeping with parents or caregivers. The recommendation from the American Academy of Pediatrics is that an infant should sleep in their parent's room so that they can be attended to whenever they need attention, but they should be on a separate, firm surface designed for them. This is the recommendation. Infants should not sleep in their parent or caregiver's bed. Swaddling is a practice that has happened in a lot of other cultures and has kind of slowly become part of United States culture as well, in terms of taking care of babies and helping them to feel calm and secure. This is the practice of where you take the child and you kind of gently wrap them up like a burrito, like you see here in this picture where only their head is outside of the wrap. Now again, swaddling is good for keeping babies warm, helping them feel calm and secure. Swaddling, however, should not be done once the infant reaches an age where they've gained enough strength in their core so they can start rolling over. Because a swaddled infant, if it's able to roll over, it can very easily suffocate. So there's not a whole lot more to be said about unintentional injury deaths in infants. It really is a case where we're kind of relying on engineering and design to sort of remove many of the hazards that an infant might face in their sleep environment. We also have to rely on education and training for parents and caregivers to know how to respond to when the infant is crying, and we'll talk about that a little bit in the child abuse part of this lecture. I mean, we really cannot train infants on how to avoid dangerous environments. They're not at a stage of development where that's a possible thing to do. So therefore, we really do rely on caregiver education and on engineering and design, sort of upstream solutions to try to keep infants safe. Next, we are going to cover child abuse and child maltreatment. But first, I must issue this trigger warning. If you're a survivor of child abuse, you might not want to proceed with this section. Please do not proceed with this section if you feel it is not safe for you to do so. You can fast forward to roughly the 56-minute point of this video, and you will be past this section. If you are an adult survivor of child abuse and you need to talk to someone, the Crisis Support Services of Nevada are available 24/7. You can call them 1-800-273-8255, or you can text the word CARE to 839-863. So the definitions of child maltreatment for legal purposes will vary, or can vary, from state to state. In the next slide, we'll talk about the Department of Health and Human Services definition for child abuse. The Child Abuse Prevention and Treatment Act has provided minimum standards for defining physical child abuse, child neglect, and also sexual abuse. CAPTA has also ensured that every state must incorporate into their statutory definitions how they define child abuse and child maltreatment if they want to receive federal funds. CAPTA has also been amended several times over the years, including in 2015 to include child victims of sex trafficking as another protected category, and in 2017, in response to the opioid epidemic, it started to include if you have an infant that's born addicted to substances as a result of maternal addiction to opioids or other drugs. This was also considered a protected category covered under CAPTA. So the Department of Health and Human Services has a definition that covers both child abuse and neglect because the definition integrates both actions and also failures to act. In this case, child abuse and neglect is defined as any recent act or failure to act on the part of a parent or caretaker which results in death, serious physical or emotional harm, sexual abuse, or exploitation of a child. Interestingly enough, the definition also includes an act or failure to act that presents an imminent risk of serious harm, even in a situation where this serious harm has not been inflicted on the child yet, but they're being put in a dangerous situation. So, for example, children joyriding in the back bed of a pickup truck, unbelted, even if the children want to do it and think it's fun, that would be considered child abuse and neglect by the strictest definition, because you're acting in such a way that presents an imminent risk of serious harm to a child. There is a substantial burden on societies, on families, and especially on children who are impacted by child maltreatment. This suffering and these physical and mental health effects and some of the costs that are associated with that over the course of a lifetime can really add up. It's estimated that in a 365-day span, a 1-year span, the total lifetime cost of child maltreatment in the United States will come to about $428 billion each year. In terms of the number of referrals that occur as a result of suspected child maltreatment, these numbers are also staggering. In the year 2015, there were 4 million referrals, which covered 7.2 million children. These maltreatment referrals were received by state and local agencies. That averages out to nearly 6 referrals every single minute. Of those referrals that are investigated, about 1 in 5 are found to be victims of abuse or neglect. This means that the rate of abuse and neglect is about 9.2 per 1,000 children. So almost 1% of all children in the year 2015 were found to be victims of abuse or neglect. Again, it's a staggering and very sad statistic. So one of the most important provisions of CAPTA is that it requires every state to come up with rules for mandatory reporters. These are people who, based on their profession, based on their ability to interact with children and maybe possibly notice signs and symptoms of abuse and neglect, are mandated by these rules to report if they see anything they suspect might be child abuse or child neglect. Here in the state of Nevada, the mandatory reporters include just about everybody that works in the medical field, certainly hospital physicians, psychologists, therapists, social workers, counselors. Coroners are required to be mandatory reporters, as are members of the clergy. Anybody that works in a public or private school, even if only as a volunteer, are a mandatory reporter, along with people who are licensed to run foster homes, attorneys, anybody who works in law enforcement, not just the sworn law enforcement officers, but other employees as well. So you can see the whole list here. There are a lot of us, including myself, who are mandatory reporters. So if we are made aware or we suspect that a condition of abuse or neglect might be happening, we are required to report it. Like so many other public health problems, there is a profound socioeconomic and demographic gradient in the burden of child maltreatment. It's not uniform across demographics. There's some substantial disparities. Children under 1 year old are much more likely to suffer from child maltreatment, along with children in low-income families, children who grow up in single-parent households, or that have a non-biologic caregiver in the home. Increased risk of child maltreatment is also associated with lower parental education levels and with parental history of being a victim of child abuse. And it would probably not surprise you to know that there's a very strong correlation between intimate partner violence in the home and child maltreatment. Child abuse takes many different forms. Physical abuse and neglect are probably the two forms that most closely match up with what we consider to be injuries. This is an injury prevention and control class, after all. Both physical abuse and neglect can result in physical injuries to a child. These other forms of abuse, though, some of them actually also lead to physical injuries. They certainly lead to emotional injuries. And I'm going to briefly at least discuss some of them, even though you might think that this goes beyond the scope of an injury prevention and control class. But these include sexual abuse and exploitation, emotional abuse, parental substance abuse, which can certainly, especially in utero, create addictions in children and can create a very dangerous environment for children. And finally, abandonment, which is really kind of a form of neglect as well. Physical abuse and neglect are the two categories of abuse which most closely match up with the definition of injury that I gave to you earlier in the course when we were differentiating the difference between injuries and illnesses. Physical abuse and neglect are also the two categories of abuse which are most likely to lead to child fatalities. If we look at the U.S. Department of Health and Human Services 2019 Child Maltreatment Report, where they've documented in the year 2019 all the children who died of some form of abuse, they found that 70.3% of all child abuse fatality victims were under the age of 3. There was some documentation of neglect present in 80.7% of all child fatality cases. So in other words, almost 4 out of every 5 child fatality cases that are deemed to be due to child abuse, neglect was present in more than 4/5 of them. Physical abuse is present in 44.4% of child fatality cases. What data consistently shows us, too, is that physical abuse death rates tend to go down as children get older. This makes sense if you think about it, because as children get older, they become stronger and more independent. They're more able to verbalize their opposition to their environment. Obviously, they're still vulnerable to their environment because they're not adults yet on their own, but they're at least able to verbalize some opposition. The power dynamics can change a little bit. In some cases, when you get into adolescence, children even have been known to fight back against physical abuse. But with the first couple of years of life are when children are most susceptible to death or serious injury from physical abuse. So when we talk about child neglect, we're talking about these actions, and there's many different categories of actions that can cause physical injury to a child because of a neglectful condition, or also emotional injuries. We're not talking about direct physical violence when we talk about child neglect. Instead, we're talking about there can be forms of physical neglect where, if these things occur, children are more likely to suffer from injuries, developmental delays, and certainly emotional injury. When we talk about physical neglect, we're talking about things such as abandonment. Abandonment means the desertion of a child without arranging for reasonable care and supervision. That's something you just cannot do if you're a caregiver, if you have a child who's not of age where they can take care of themselves. Expulsion means other forms of blatant refusal of custody, such as permanent or indefinite expulsion of a child from the home without adequate arrangement for care by others, or the refusal to accept custody of a returned runaway. This is certainly something that happens more in children in adolescence and the early teenage years when there's a lot of conflict between caregivers and children. But it's considered a form of physical neglect to refuse custody and to expel a child from your household. Shuttling, that'd be where children get passed from one household to a member to another and don't have stability. Nutritional neglect, which is exactly what you think it is, where the nutritional needs of a child are not met. Same with the clothing needs not being met. That's clothing neglect. Medical neglect means that you deny health care to a child so that they don't thrive. There are some religious exemptions for this. There are some different sects that don't believe in childhood vaccinations, for example. In that case, has to be a well-documented religious exemption. You can't just deny necessary health care and preventive medicine to a child. You also cannot delay health care for a child who desperately needs it. Educational neglect basically means that you're not enrolling your child in school or not enforcing them going to school until they reach an age where they can make a decision about whether or not they're going to continue at school. If you permit chronic truancy, fail to enroll your kid, or the child has a special education need and you completely fail to make sure that it's addressed in the educational setting, that's considered educational neglect. Emotional neglect means that you withhold nurturing and affection, that you living in a household where there's chronic or extreme spousal abuse is also considered emotional neglect for children. Permitting drug or alcohol use in such a way that children are affected either by secondhand smoke, by firsthand smoke if you don't properly supervise cigarettes, and the same with alcohol. Permitting other maladaptive behaviors. There's been times when people have been arrested for emotional neglect for allowing very young children to operate things like riding lawnmowers and tractors and things like that. Refusing or delaying psychological care, and isolating your children, not allowing them to interact and to have normal, healthy environments is considered emotional neglect. Inadequate supervision, I kind of hit on this before, where you allow children to be exposed to hazards, you don't supervise them properly, when they're put in the charge of caregivers who are not up to the task or for various reasons. And this is relatively new as of 2017. If a baby is born addicted to opioids, for example, or other forms of drug, that they received in utero, that's now considered a form of child neglect for which charges can be filed and from which children can be taken out of homes. Emotional abuse is a form of psychological maltreatment that is defined as a repeated pattern of caregiver behavior or extreme incidents that convey to children that they are worthless, flawed, unloved, unwanted, endangered, or only of value in meeting another's needs. This definition comes from Hart and Brassard. Some forms of emotional abuse include spurning. This is where the child is ridiculed, hostilely rejected by their caregivers, or belittled repeatedly. Terrorizing. This is where physical violence doesn't necessarily happen, but is continuously threatened against a child, or when children are placed in recognizably dangerous situations in order to make them feel terror. Isolating. This can also be a form of neglect as well. This is where you confine a child, place unreasonable limitations on their freedom of movement, and restrict them from social interactions. This can have a devastating impact on child development. Many years ago, there was a story of a young girl in California named Jeannie. Jeannie Wiley was her name, and she was essentially a feral child. She was never given any, she was isolated, was completely hidden away from the rest of the world for almost her entire childhood. And to this day, what I understand, she is still alive, but no one's heard from her in several years. To this day, the profound emotional difficulties and physical difficulties she's had to deal with are still with her. Other forms of emotional abuse, which can also present grave physical danger to a child, is exploiting or corrupting them. So, in other words, modeling antisocial behavior, such as criminal activities. If you're a caregiver of a child and you have that child help you in, say, the commission of a robbery or something, that's a clear example of exploiting and corrupting. If you encourage your child toward prostitution, or if you permit them to abuse substances, this is also exploitive and corruptive behavior. Denying emotional responsiveness is both a form of neglect and also a form of emotional abuse. If children's attempts to interact are rebuffed by their caregiver and no affection is expressed, this is emotional abuse as well as neglect. And again, as we talked about briefly before, mental health, medical, and educational neglect, besides being neglect, is also considered emotional abuse. If you fail to provide treatment for serious mental health or medical problems in a child, if you ignore their need for services or serious educational needs, this is also considered emotional abuse. So in your prior education in public health or medical education, you've probably been made aware of the Adverse Childhood Experience Study and ACEs, or Adverse Childhood Experiences. I'm going to reiterate some of the important things from it because this is very critical as to why we need to prevent child abuse and child neglect, because it's one of the many things that can have a devastating effect on somebody's health and on population health in the long term. The Adverse Childhood Experiences Study is one of the largest investigations ever conducted to assess associations between childhood maltreatment and later life health and well-being. The initial results from the ACEs study were published in 1998, but that cohort continues to be studied and monitored even to the present day, and will probably continue to be monitored for many years going forward as well. The study is a collaboration between the Centers for Disease Control and Prevention and Kaiser Permanente's Health Appraisal Clinic in San Diego. The N equals 17,000. It's actually more than 17,000 health maintenance organization members who undergo a comprehensive physical examination, and then they chose to self-report detailed information about their childhood experiences of neglect, abuse, and family dysfunction. It does rely on self-report data. That is one of the recognized limitations of the ACEs study. The ACE study findings suggest that certain experiences are major risk factors for the leading causes of illness and death, as well as poor quality of life in the United States. It is critical to understand how some of the worst health and social problems in our nation can arise as a consequence of adverse childhood experiences. Realizing these connections is likely to improve efforts toward prevention and recovery. The original 10 adverse childhood experiences that were in that 1998 published study and with that initial cohort are the following: recurrent physical abuse, recurrent emotional abuse, sexual abuse. In this case, it doesn't have to be recurrent. If you have even a one-time event of sexual abuse in your childhood, that's considered an adverse childhood experience. Having someone in your household who abuses drugs or alcohol. Having someone in your household who is currently or formerly incarcerated. Having someone in your household who is chronically depressed, mentally ill, institutionalized, or who has had suicidal ideation, or who has died by suicide. If a mother is treated violently in the household by a partner, a boyfriend, somebody else in the household, that's another adverse childhood experience. Having parents who are separated or divorced, emotional neglect, and also physical neglect. These are the original 10 ACEs. Many other researchers have picked up the idea of ACEs and have kind of built upon the original work, which tended to focus a lot on individual and familial experiences. Subsequent ACE studies have considered additional ACEs at a more community level. One example would be the Philadelphia ACEs study. Their expanded ACE questions considered the following types of community-level adversity, which, if you were exposed to these as a child, was considered an adverse childhood experience. If you witnessed violence, it didn't have to be in your household, it could just be in your neighborhood or your community. If you've known someone to be beaten up, stabbed, or shot in real life. If you felt discrimination. If you ever felt you were treated badly or unfairly based on your race or ethnicity. If you had any kind of adverse neighborhood experience, such as feeling unsafe in your neighborhood, feeling like people in your neighborhood were not looking out for each other, could not be trusted. If you were ever bullied, again, we're talking about outside of the household by someone like a peer or a classmate. And if you ever lived in foster care. Again, these are community level ACEs. There are more than 40 negative outcomes for which ACEs have been shown to have a graded dose-response relationship. In other words, the more ACEs you have, the more likely you are to have had these negative outcomes. As your ACEs score goes up, so does your risk for risky behaviors, for things like being physically inactive, smoking, abusing drugs and alcohol, and engaging in early sexual activity. Your risk for chronic diseases goes up as your ACEs score goes up. You're more likely to experience obesity, chronic obstructive pulmonary disease, asthma, diabetes, liver disease, and heart disease. You're also at greater risk for other health outcomes, such as teen pregnancy, sexually transmitted diseases, miscarriage, depression, suicide attempts, early death, lost time from work or problems holding a job, and also perpetration of intimate partner violence. This graphic is taken from the CDC's ACEs Resource Center. The point of this graphic is to compare how likely a person with 1, 2, 3, or 4 ACEs will experience certain negative physical and mental health outcomes or engage in certain unhealthy behaviors as compared to a person without any adverse childhood experiences. So if you look in the upper right corner, this is the data for people with self-reported ACE scores of 0. They had none of the adverse childhood experiences. You might not be able to tell what every single one of the bubbles represents. Each one of them represents either an unhealthy behavior or a negative physical and mental health outcome. And you can kind of get the gist of it by looking at each of the bubble clouds based on whether you get an ACE score of 1, 2, 3, and 4. When you get into people that have 4 ACEs, you see that in particular, the bubbles for suicide attempts, for alcoholism, for drug use are very profoundly larger than they are for people with an ACE score of 3 or 2 or 1 or especially 0. If you're wondering how common adverse childhood experiences are here in the United States based on self-report data, approximately 64% of Americans surveyed have had at least one adverse childhood experience. Only 36% of surveyed Americans report 0. 12.5%, that's 1 out of every 8 Americans surveyed, has 4 or more adverse childhood experiences. That's a very substantial portion of our population. Data has consistently shown that survivors of one form of violence are more likely to be victims of other forms of violence. Now, before we go any further here, it's very important to note that while being a survivor of one form of violence increases the likelihood that an individual will experience another form of violence. Being a victim of multiple forms of violence is not inevitable. We're talking about likelihood, which refers to the probability of re-victimization as compared to non-victims. It never means always. So now to the data. Girls who are sexually abused are more likely to suffer physical violence and sexual re-victimization. They're more likely to engage in self-harming behavior. Later in the semester, we're going to talk about non-suicidal self-injury, one of the most common forms of which is cutting. They're also more likely to be a victim of intimate partner violence later in life. Youth who have been physically abused by a dating partner are also more likely to have suffered abuse as a child, been a victim of sexual assault, or witnessed violence in their family. Again, they're more likely to have had some specific adverse childhood experiences. Women and girls who are involved in gangs often experience physical, emotional, and sexual abuse by other gang members, and they're also more likely to have been physically or sexually abused as children. Again, keep in mind, these are just likelihood and probability statistics. They're not predictive of any one person's outcomes. With youth who report attempting suicide, it's been found that there's approximately 5 times more likely that they had been in a physical fight in the last year. There's a very strong correlation between physical altercations and the beginnings of suicidal ideation. Children who have been bullied are at a greater odds of becoming involved in physical violence, such as carrying a weapon or being engaged in physical fights with their peers. We've gone over a lot of very grim statistics about child abuse, so now let's turn our focus to prevention. Prevention programs for child abuse have traditionally focused mostly on education for individuals or families. This is important, but as the Zimmerman and Mercy article, which was assigned to you this week, shows, it is also critically important to take a systems approach to prevention of child maltreatment and develop strategies at the community and population level. With that said, we will first address some of the evidence-based educational programs that are used for families, parents, and even for children. There are many forms of media that have a pretty good evidence base to show that if they're shown to parents, maybe with a test or exam afterwards, it does help to convey certain skills in how to deal with the stresses of new parenthood and the stresses that children can bring, and to not resort to abuse or violence or neglect. We know that parental education and support groups are another evidence-based intervention that occurs a lot. These often will also include structured parent-child interactions where parents and children are put into an observation room and their interactions are observed and documented, and any kind of problematic interactions that are seen is a chance to sort of stop and refocus and retrain. These are very effective. The sad fact, though, is that a lot of the parents that probably most need these types of programs are the ones who are least able or least likely to seek them out. There also are programs given to children themselves to teach them about assault and abuse prevention. These are controversial for reasons that you can easily imagine. Why should children be exposed to the idea that they have to protect themselves when it's the adults around them who should be feeling that stress and that strain to not do these activities? There are programs that will educate children on physical and sexual abuse and teach them how to avoid risky situations and how to respond if they feel like they are being abused. And again, there's evidence base for this. It can be a good thing, but it can also be very controversial because, again, the training itself can be traumatic for a child. There's also a whole field of something called repressed memories, which is very controversial, which has been, you might have heard about these before, about how sometimes after receiving training, children will start reporting abuse that didn't actually happen. Now, this is rare. It's very rare. Most of the time when a child reports discomfort or abuse, there's a legitimate reason for it. But this is one of the reasons why programs that focus on training children can be problematic. What these programs do, though, and I got to give them credit for this, they're effective at providing skills to avoid and minimize risk, and they give children language tools and procedures to access help that they maybe would not have known about if they had not received the training. Another evidence-based prevention strategy that reduces both incidences of childhood abuse and also other adverse childhood experiences is early home visitation. This is where professionals will go to visit parents of infants or young children, and they will provide education regarding infant health and development. They will show ways to model positive adult-child interactions. They'll provide social support and assist parents in achieving specific life outcomes that are drawn up ahead of time, such as further education. This is very important. Even though there's a strong base of evidence to support this, one concern people have about early home visitations is what we in epidemiology call the Hawthorne effect. This idea that when you're observing something, when you're observing a behavior, you're actually changing the behavior just by the fact that you're observing it. And it's impossible to know what the behavior would be if you were not there observing it. And that's just something we always have to deal with in social sciences and epidemiology, in cohort studies, and whenever we're trying to convey skills to parents. It's something that's very important, though. What's probably just as important, maybe even more important, is to look a little bit wider beyond just the household. Look into forming community partnerships to try to encourage multiple entities to work together to protect children and support families. When families feel like they're supported in their community by their employers, by their neighborhoods, that can make a really big difference. When families feel isolated and they have no support, this often is when adverse childhood experiences can result. And as we know, adverse childhood experiences can be at the community level as well. Children can perceive if their neighborhood is not a safe place for them to be, if their neighbors are not watching out for them. They can also perceive the opposite, if they are in a safe neighborhood, and if they have a bunch of people that have their back. So community partnerships are one of the most important preventive strategies, but also public awareness efforts. There have been campaigns to mobilize the public and influence societal beliefs about parenting and abuse. In particular, there's been a big shift in social norms in the past decade in regards to spanking and other forms of corporal punishment. Several years back, there was a very famous running back in the National Football League who he didn't have sole custody of his 4-year-old son, but whenever he did have custody of his son, his son came back from visiting his dad and had several welts that had been administered with a stick. And later this football player admitted that, he had whipped his son for doing some things that the father thought was not acceptable behavior for a 4-year-old. Well, this resulted in fines and suspensions from the league and just a lot of dialogue about corporal punishment and about how physical punishment, especially to younger children, how it doesn't correct behavior, it doesn't make children, it just is it's a form of abuse. And that's an example of a social norms campaign that's really been effective in the past decade. So earlier, I referred to that Zimmerman and Mercy article, which talked a lot about how we need to take a systems approach to child abuse and maltreatment prevention. And part of that is, sort of changing the lens of prevention of child maltreatment to try to take a more proactive approach rather than a reactive approach. And here's some examples of what a reactive approach to preventing child abuse might say versus what a proactive approach might say. If the question is, what is the problem? A reactive approach would say, it's poor parenting. We need to go in there and educate the parents. A proactive approach would say that there's a lack of both formal and informal societal support of parents and access to new information. What created the problem? A reactive approach would say that it's upbringing, substance abuse, or parental choice, Whereas a proactive approach would say that having a society with short-term vision where children are not treated as are treated as a nuisance or something that interferes with productivity of society. Outdated theories on raising children, such as the idea that 4-year-olds should be spanked, and repeatedly with a stick, and also just declining communities, not feeling a sense of community. How is this problem going to be solved? The reactive approach says it should be child protective services, police, foster parents, parents fixing themselves, pulling themselves up by their bootstraps. Proactive approach would say that you need to have community leaders with vision, you need to have friends and neighbors involved, healthcare system involved, faith groups, doctors, schools, the whole entire community involved in preventing child maltreatment. And then the question of what created it. The reactive approach says you need to rescue children, punish parents, let children heal themselves, whereas a more proactive approach says that we need to develop new information about development, we need to have more social interactions and parent support, and more reinforcement of positive behaviors. So ultimately, successful public health strategies for dealing with child abuse will weave together programs, policies, and people. They will change social norms, encourage community action, educate the public. Education is still an important part of this, and will advance policies that support families and that value young children. Again, parental leave policies are one of the most important things we could do in jobs here in the United States, and we just don't do it. We don't have a society that appears to value parenthood or that makes accommodations so that parents don't have to be so stressed out all the time. We can and should go far beyond individual-focused efforts on this problem that just try to convey educational materials about what not to do and what to do when you're trying to raise a child. Think about, and this is an example that was brought up in the Zimmerman and Mercy article as well. Think about smoking efforts and our efforts against smoking. How in the last several decades, it's gone well beyond just giving educational support to people about how to quit. Most people know how to quit now. It's difficult to quit, but most people do know how to. We've since moved on to more policy level things that like limiting exposure to secondhand smoke, increasing the taxes on cigarettes so that there's a financial incentive to reduce or quit smoking. These are all programs that seemed weird and exotic not that long ago, but now they're just kind of accepted and normal. These same kind of approaches could be used for child abuse prevention as well, if we just had the will to do so. One very effective prevention program mentioned in the Zimmerman and Mercy article is the Nurse Family Partnership and Home Visiting Study. This was started back in 1977 in Elmira, New York, but since then it's still going to the present day and currently reaches more than 20,000 families per year in 25 states. What this program started out as is registered nurses making home visits to young, first-time low-income mothers over the first 2 years of life. These programs were found to improve parental health, reduce childhood injuries. There were fewer subsequent pregnancies in families that had this intervention early on, increased maternal employment. A 15-year follow-up, with this program starting in 1977, showed that there was a 48% reduction in child abuse and neglect in families that received this home visit, that were part of this home visiting study versus control families that were not. The home visit programs are now recognized as an effective child maltreatment prevention strategy. Child abuse is most likely during specific developmental stages, one of those stages being the period of infancy where infants cry the most. This is also when the incidence of shaken baby syndrome tend to be the highest. Now, shaking can cause severe permanent damage and even death to babies. It's something we want to prevent. The Purple Crying Initiative was started in North Carolina as a way to prevent shaken baby syndrome. It provides parents with information at birth about crying and how to respond to a crying infant, things that work, things that don't, ways to de-escalate your own feelings about what's going on, ways to not block out the distress that is coming from your infant, but just how to better respond to it. And this information is reinforced through routine well baby visits. Here in Nevada, we've picked up some of these Purple Crying Initiative things. There's an organization called Prevent Child Abuse Nevada that administers this here in our state. And in fact, we have the Nevada Institute for Children's Research and Policy, which is housed in the School of Public Health at UNLV, that administers this and does a lot of the research and refining of it. The Triple P Positive Parenting Program came from Australia but has since been brought to the United States. It's a way to promote positive parenting and reduce child behavioral problems. This program is based on scientifically supported interventions that have been proven effective in several randomized clinical trials. Triple P also has 5 graduated levels of intensity, which range from media-based social marketing campaigns all the way up to individual consultations. Parents themselves set the goals for their own participation in Triple P, and they take responsibility for choosing the strategies that best suit their families. And now we will move on to the topic of elder abuse. This is an issue that's only going to get more significant in the U.S. over time, because current census projections are that by the year 2034, the population of people who are 65 and older will outnumber the population that's under the age of 18. The U.S. Administration on Aging defines elder abuse as any knowing, intentional, or negligent act by a caregiver or any other person that causes harm or a serious risk of harm to a vulnerable adult. Elder abuse can take many forms, such as physical abuse, where you inflict physical pain or injury through slapping, bruising, or restraining by physical or chemical means. It can include sexual abuse, which is any non-consensual sexual contact of any kind. And non-consensual sexual abuse includes any kind of contact with somebody who cannot consent, possibly because of advanced dementia, for example. Neglect. That's the failure by those responsible to provide food, shelter, health care, or protection for a vulnerable elder. One sign of neglect that's often seen in home care and other places is bed sores, where clearly the needs of a senior are not being addressed if they're developing bed sores. Exploitation. This is the illegal taking, misuse, or concealment of funds, property, or assets of a senior for someone else's benefit. Seniors are very prone to exploitation in our current culture, unfortunately. Emotional abuse is the infliction of mental pain, anguish, or distress on an elder person. It can be through either verbal or nonverbal acts, such as threatening, intimidating, or humiliating. The desertion of a vulnerable elder by anyone who has assumed the responsibility to care for them or to assume custody of them is considered abandonment and is another form of elder abuse. Sometimes elders living alone will also engage in self-neglect, where they fail to perform essential self-care tasks, and that failure threatens their own health or safety, as well as possibly the health and safety of others in the facility or building. One of your assigned readings for this week was the Acerno et al. Article, which spells out the National Elder Mistreatment Study that they undertook. They had a total of 5,777 elderly subjects in this study. It was found that 4.6% of these subjects had suffered from some form of emotional abuse. Of those that suffered emotional abuse, a little bit under 8% actually reported it to the police. Over 92% did not report it. 1.6% of all subjects had suffered physical abuse. And among that number, only 31% reported that to the police or any other authorities that could act on it. 0.6% of those 5,777 subjects had reported sexual abuse, with only 16% of it reported to authorities. A little over 5% of subjects reported some form of neglect, and 5.2% had reported some financial abuse or financial exploitation of them. Among those in this study who had suffered mistreatment, there were some risk factors that were consistently associated with risk for mistreatment. These include being in a shared living situation or being socially isolated. Both of those are actually risk factors for mistreatment. Having dementia, depression, substance abuse, having an abuser that's dependent upon the victim, for example, financial support. Health and functional status were also inversely correlated with mistreatment, meaning that the lower your health and functional status, the more likely you were to have mistreatment. There were some demographic factors that made you more likely to suffer neglect. Being in poor health, being non-white, being of low income, and having low social support. Maybe not having family or friends nearby who would check on you. These all increase the risk for potential neglect. Another surprising finding of the National Elder Mistreatment Study was that the subjects who were considered young-old, meaning they were over 65 but less than 70 years old, were at an increased risk for physical, emotional, and financial abuse. Now, this may be due to underrepresentation of institutionalized adults in this study sample. And also, the ability to respond to a study might have been skewed more toward younger subjects. But that was an interesting finding. Those with low social support were at increased risk for all forms of abuse. When we look at statewide data from the year 2014 that gives a scorecard of the long-term care capabilities in a particular state, we find that Nevada does not do very well. It's in the bottom quartile, ranked overall 41st among the 50 states in the District of Columbia. Now, in affordability and access to long-term care, Nevada ranks 32nd. They also ranked 24th in support given for family caregivers and 32nd in effective transitions, meaning transition from a home environment to a long-term care facility environment. But in ranks of choice of setting and provider and quality of life and quality of care, Nevada ranked 40th in both of those. So there is much room for improvement here in Nevada. Another study was conducted by Schiomberg and colleagues back in 2012, and they found that in skilled nursing care facilities, 24% of respondents in a survey they did reported at least one event of physical abuse from nursing home staff. It's almost 1 in 4. Again, that's a pretty profoundly high number. Here in Nevada, we have regulations that help to ensure that nursing home and skilled care facilities are healthier places for elderly adults to be. These regulations have to do with staffing levels, and they're codified in Nevada Revised Statute 449.017. For any facility with more than 20 residents, they have to have at least one awake staff member plus an additional person available within 10 minutes. For facilities that are licensed for 20 to 49 residents, they must have one staff member designated to organize, conduct, and evaluate all activities. And for facilities with 50 or more beds, they must have a full-time person for all activities. A very important piece of federal legislation was the Older Americans Act of 1965. This act established the Administration on Aging. It also promoted the well-being of older individuals by providing services and programs designed to help them live independently in their homes and communities. It also empowered the federal government to distribute funds and grants to the states for supportive services for individuals over the age of 60, again with the goal of sort of helping people live independently in their homes and communities, assisting with transitions to long-term care facilities when that's necessary, and just otherwise trying to improve the quality of life during a time when, if there's no support, quality of life can go badly very quickly. Prevention of elder abuse starts with screening programs, where you can use interviews or even direct observation of older persons and sometimes the family members who are the caregivers of older people to identify potentially abusive situations, the goal being to predict possibility of abuse before abuse occurs. There are certain indicators that they look for, that if they see them, that kind of is a red flag that there's a potential for abuse and that maybe a little more scrutiny is necessary. Just like with child abuse and with sexual assault on college campuses, there's mandatory reporting if elder abuse is suspected. And it's a lot of the same people that are required to report this if they suspect that it's the same case, medical personnel, religious personnel, educational personnel in settings where that's applicable. Every state has adult protective services. They're all expected to have a certain baseline level of services that they provide if they receive federal money. But beyond that, the protective services do vary from state to state. Education of professionals is another important prevention step where we can increase the awareness of potential signs and symptoms. Things like bed sores and other marks that indicate that abuse might be occurring. How to find these, how to gently query about these things. Because it is believed that stress on the caregiver increases the risk of elder abuse, and there's plenty of evidence to show that this is indeed the case, that's why caregiver support interventions are another popular prevention strategy. Also, awareness campaigns that are culturally appropriate for seniors are often used in order to educate them on signs that their caregiver might be abusing them or might be prone to abuse, and that I'll encourage victims to report such things. There are also legal and victim advocacy services which tend to use the same models used for intimate partner violence, where there'll be social support given to the victim, there'll be various forms of self-help that can maybe help people get out of a bad situation, plus shelters such as emergency shelters and safe houses, and also remedies and revenues for legal action as well. Here are some closing thoughts as we get near the end of this module. First of all, I should reiterate that infants have unique biological and physiological fragilities that make them vulnerable to unintentional injury, mortality, and morbidity. And of course, because of their stage of development, infants cannot be given education on how to avoid unintentional injuries. We have to rely entirely upon training and education of caregivers, and also design of systems to ensure that equipment that is used to take care of infants is safe for them as well. For children and the elderly, effective injury control and prevention will involve both individual education and systemic changes at the wider level, such as community and society. Yes, individual education will always be important, educating both children and the elderly about signs of abuse and how to speak up, how to report conditions that concern them. That's important. But the systemic changes, having a systems approach, is always going to be more important. If we can develop a community and therefore a society that embraces children and seniors, that actually works with them and cares for them, that would be an ideal and better society. And we would get a lot more benefits from our public health dollars if we could focus it on that. And so here's some of the additional references that were used throughout this presentation, along with the assigned readings that you had. If you have any questions or concerns, let me know. Thanks for your attention today.